Good morning, and thank you so much for joining us at our Diabetes Care During the Pandemic webinar, where we'll be looking at the critical role of innovation over what is now nearly been the last full year of the pandemic. My name is Morgan McKean. I'm the NHS Innovation Accelerator Communications and Engagement Manager. You'll hear today from 4 of the fellows on our accelerator program speaking about their learnings over working within the COVID period, as well as what their innovations can offer the NHS right now. We'll also hear from Professor Partha Kar, who will take us through more of a national context setting of where we are with innovation within diabetes care. To kick things off, I just thought I'd give a quick overview of what the NHS Innovation Accelerator, or NIA, is. We are an NHS England initiative delivered in partnership with England's 15 academic health science networks across England. And we are hosted by UCL partners here in London. We really have 2 main reasons for existing. One is, of course, to support the uptake and spread of high impact evidence-based innovations across the NHS in England so that we can ensure more patients, populations, and NHS staff are benefiting. We also exist to take the learnings that we gain from our fellows on the program, who are obviously working on the front line as innovators, and take those practical real-time insights and use them to feed back into the system to help inform national strategy and really give a sense check as to where the NHS is with adopting innovation. So I quickly wanted to take you through what our selection process is so that when you hear from these 4 innovators later on, you'll understand the rigorous multi-stage process they have gone through to be able to join the NIA and kind of where those ticks of approval have come along the line. So firstly, we ask applicants to submit information about themselves, about their innovation, and about their scaling strategy. We really make sure that each person who joins and becomes a fellow is someone who is keen to learn from others and, importantly, to share their learnings elsewhere. So we, at that stage, identify that there is a significant evidence base that's able to be demonstrated, as well as some ability to show cost savings to the NHS, and of course, a need for that innovation within the NHS. Those that go through the assessment process are then informally reviewed by both NICE and the National Clinical Directors to ensure nothing's at odds with national strategy. And then we invite those who have been shortlisted to an interview, which includes a range of expertise, also present during the assessment phase of clinical, commercial, patient experts from across NHS England and NHS Improvement, the Academic Health Science Network, clinicians, and of course, like I said, patient and public representatives. Once interviewed, recommendations are then put to our decision-making group, which is our program board, chaired by Professor Stephen Powis, National Medical Director for NHS England and NHS Improvement. Those that are put forward and recommended are reviewed, and those who are then accepted onto the program go through one final stage of due diligence, where we look to ensure they have all the correct regulatory markings like CE marking, and that they meet the correct governance guidance for what's needed for that innovation to be implemented. So hopefully this just can quickly show that each of the fellows on our program really have been quite vigorously assessed to ensure that they are bringing an innovation into the NHS that's both needed, able to save costs, and also will really help benefit patients within our NHS. Very quickly, just to highlight the impact of our NIA fellows to date. As I might have said, we were started in 2015, so this is our 5th year coming on 6th year, and we have we're incredibly proud of the fellows on our program. So we have independent evaluations by York Health Economic Consortium, which have shown that NIA innovations are saving the health and social care system £38 million per year, and that's real figures, not based on estimates. And actually we'll be publishing a new YHEC report at the end of this year, which shows around £60 million savings per year. NIA innovations are being used in nearly 2,400 NHS sites, Over 120 awards have been won by our fellows, and 155 million pounds in external funding has been raised by our fellows and brought back into the system. So as I mentioned, one of the remits of the NIA is to ensure that we are sharing real-time practical insights with the system. Our fellows are really a national resource able to help us learn about spreading innovation in the NHS, about adoption and implementation. And so we really want to make sure we're capitalizing on that and sharing it as far and wide as possible. Each of the individuals who come on our program, as I mentioned earlier, have a real commitment to sharing their learnings and to being part of the fellowship. So we take that, gather their case studies, blogs from our fellows and from across NHS England, articles, podcasts they've put together, and put them in an Insights newsletter, which goes out quarterly, and also into annual research outputs. So these research outputs highlighted here from 2018 and 2020 really look at what are the key enablers for both innovators trying to get implementation going, and also for adopter sites looking to bring innovation into their area. I encourage you to sign up for our Insights newsletter, as well as to look at these research outputs on our website. They are all available through links on our homepage. So before I pass it over to the rest of the speakers, I just wanted to quickly take you through some of the information that we've gained through our fellows. I guess it was back in about July now, of kind of what they had seen as COVID-19 was going on. One of the things that we were really kind of impressed by, although we should have expected it, is the ability for rapid adaptation that our fellows were able to show. So really across the board, every single one of them looked at where they could make adjustments, make some small pivots or big pivots for some of them, to ensure that their innovation continues to meet the needs of the system as it's functioning right now. We also heard from our fellows that there was a real increased demand for NIA innovations and innovations across the board, as well as much more rapid decision-making from those within adopter sites. In a way that was completely unprecedented previously. For example, we had one fellow who has been taken up in a hospital where he's never physically set foot into it, which is completely a new thing for him, but it was all done remotely rather than via multiple face-to-face in-person meetings, which would have been the normal case. And essentially, kind of highlighting what we're here for now, digital innovations are really being seen as more essential than ever before. They have previously been perhaps deemed too difficult or too high risk to implement, and our fellows are reporting that actually that has kind of been pushed to the side, and adopter sites are really seeing the benefit of digital, especially in this remote working space, and seeing that patients can in fact interact quite well through digital innovation. So at this point, I'd like to please pass it over to Professor Partha Kar, who is National Specialty Advisor for Diabetes for NHS England and NHS Improvement, as well as the GIRF lead for diabetes and a consultant endocrinologist. We are incredibly pleased to have him and look forward to hearing what he has to say. Professor?
What has COVID-19 done, if I could summarize that very briefly right at the beginning, it's accelerated a lot of things. That's what it's done. You know, every cloud is a silver lining, if you want to look at it that way. But what it has done at a level of clinician level, it suddenly opened up the possibility of what can be done in the way of digital. So, and the simplest example I can give of that is that as Debbie has known me for a long time, you know, and when I was a consultant, I started off, I've spent years trying to explain to people that you can actually talk to patients by videos and telephones. And I remember as clinical director in those days, when I used to be much younger than now and less tired most of the time, that I remember going to 11 meetings in a 4-month cycle, trying to explain to people why a video consultation would work and Skype would work. And I remember sitting in this and meeting and saying to, well, I can speak to my mom and dad every weekend on Skype from India. Why can't I speak to somebody who lives down the road? That makes no sense. And I still remember, and I always joke about this, but people did say that they were worried about it being hacked. I don't remember what, I remember saying that, I'm not sure why the North Koreans would like to know about anybody's diabetes consultation. And it was all sorts of weird things. Then we had things like, what would you like a chaperone in the room with you? And I'm going like, well, is that not that type of video consultation? So, you sit down and you go like, at one point you just go like, I don't know, what you need to convince people to actually understand that digital things work. And then came COVID, and then suddenly everybody's governance things seemed to disappear in like 2 days flat, which was pretty amazing. And I think a good measure of that has been my own colleagues who I work with. We have got a department of 5 or 6 people, and there's always been a bit of a split as to how many people will go down the virtual route completely, how many people won't. And now you see a lot of people going like, well, do you know what? I really don't want to go back to everything face to face. This seems to work quite well. And we're going like, yeah, we did say it would. So, I mean, if you look at the world of type 1 diabetes, for example, do I need to do face-to-face? Well, actually, rarely. That's the irony of it. There are some people you absolutely would want to see face-to-face because of the other nuances of other mental health issues you want to pick up, other issues you want to pick up. But if you're purely talking about diabetes control, especially with all the tech available, most of my type 1 diabetes clinics, they share their data. I have a conversation with them, and that's it. And you move on. And so I think to give a overview as to what COVID has done, it has accelerated a lot of the NHS long-term plans for us in diabetes. We are quite proud in the sense that we are one of the few teams which have managed to deliver a fair few things in the long-term plan already. And some of it was helped by COVID. We promised that we would get Freestyle Libre to the population. We promised 20% uptake. We're standing at 35. So, we've overshot by a significant margin. And now what we want to do is we want to devolve it all down to local economies. I think the case has been proven, some fantastic work coming from Scotland and other places, ABCD audit. It's done what it said on the tin. It's dropped admissions, it's improved HbA1c, it's improved quality of life. I'm not quite sure what else it's supposed to be doing. And so now we are saying to everybody, we're going to lift the criteria, money is going back to you. And I think people forget that we didn't invest a single penny. All we did was we sort of ring-fenced money from existing budgets and said, this is how you need to use technology. And we got there. So that's what's been delivered. Getting continuous glucose monitors to everybody who's type 1 diabetes and pregnancy is a massive leap. It's one of the few countries which have done it. We would have started it earlier, but COVID obviously held things off. So we're now starting it all through the country. We managed to make the case for people with learning disability on insulin, so that's been quite good. But beyond those technology side of things, Debbie's involved in the type 1 diabetes platform we have created, which I'm sure she will talk about. But again, we're one of the few in the world which has got a whole country platform for everybody with type 1 diabetes. Irrespective of your age, you got providers which are there and people. And one of the conversations right now I'm having is challenging the long said belief that to get X, you need to do Y. And that being Y being that you need to do a face-to-face education over 5 days. And I've said, where is that written? Where does it say you need to do that? And people then go like, oh, NICE says so. Actually, NICE never said that. NICE has not said that at all. NICE has said it's up to the providers to give you a structured education. NICE has never said that the patient has to sit down for 5 days, even though they might be wondering, I'm not sure how this is working for me. That's not what NICE has said. And I think so that's why we have accelerated the digital process within the education field. You have to have options. Face-to-face is not being taken away. It's an option for a lot of people. I have no problem with that, absolutely. But so is digital. And, if I had type 1 diabetes or type 2 diabetes, I'm not sure I could spare time to go off and sit down in a room, and then people can say, oh, you should take the time. Yeah, of course, if there's no other option, but there is a digital option. It's in 2020. So no, I don't want to do that. So I think the professionals can't quite turn around and say, oh, nobody's coming to my. So at the moment, the argument is a lot of people, which we're trying to break down slowly, is that our face-to-face programs are amazing. And you go like, yeah, but nobody's coming. So the best program in the world is the one the patient attends. It doesn't matter what your study says. I don't care about your study. They need to go there. So, and then you hear, well, it's actually really, so the uptake of type 1 diabetes education, for example, in this country, of people is about less than 10%. It has been over the last 6 years. And when you ask people, they always go, oh, the data's not right. Well, the data is right. Because you don't like it, you say the data's not right. That's what we have found all the time. And as part of the GIRFT work, I went around nearly 110 hospitals. That's what you found. People who love their data. It's a bit like, sorry if somebody misses the analogy of this, but in football nowadays, you've got this thing called VAR. If your team gets it, you love it. If your team doesn't get it, you hate it. And that's what it is with data. It's the same thing, you know? So we got that. We got a type 2 diabetes platform with digital also coming through, which I think is quite exciting. And that's challenging a lot of providers in that market. We have obviously healthy.io is there as well because the whole thing is urinary ACR checks have dropped off. We need to look at different ways of doing it. We have also worked a bit with Arjun and his team of a low carb. You know, there is this debate goes around, and me and Arjun and Charlotte, when we meet, we always smile about it, because if you go on social media, there are some absolute zealots around it. And I always go like, I never stopped it. I never stopped a single patient from trying low carb. You want to try whatever you try. I have no problem with that. You know, I'm not trying, you know, I'm trying what I try. You try what you try. The best diet in the world, I've always said, is the one which is affordable. That's the important bit in today's world. It's very easy for a lot of middle-class people to turn around and say, you should have avocado for breakfast. Well, no. A lot of mums and, you know, dads are struggling with their jobs and their lives. They can't afford it. They can afford only cheap things, which in lots of places, let's not forget, McDonald's does a pretty rubbish but filling meal for £1. So those things are important. What have we got? And I think there's a couple of other things which I wanted to finish off on, which I think is going to be quite important for us. We are now starting on work on some data interoperability. I think we need to set some standards. We will get it done, because I think from a clinician point of view, I don't want to sit in clinic and open up 65 platforms to do a clinic. That is ridiculous. I don't want to do that. And neither does the patient. You know, simplistically put, and I always say this to NHSX and everybody else, because we are asked, what things can be solved? And you always go like, well, I tell you what you can solve. This is what I would like. I would have liked it ever since I became a doctor. I would like to sit in my clinic, open one platform and see everything of that patient with diabetes. I would like to see the retinal screen, the foot screen, everything done in one place. And so with the patient, solve that for me. I don't want any other fancy stuff. Just solve that for me. You would have improved diabetes care. I want to see what my GP colleague has done. I want to have one place where you can input stuff. And finally, the other thing which we are going to tackle on is procurement. So, because what you find in the country with technology is that if you go to Derby, you can have 2 types of pump. If you go to London, you can have 4, but they may not be the same. So if you read about a pump which works in X way and you go to a place and go like, can I have that? The answer is not really, because that's not what we procure. Well, that's silly. I'm pretty sure the N in the NHS stands for national. So my view is that I think there should be only one pathway for the whole country. It doesn't matter where you are. You should have access to every single pump and technology. And I think the future of type 1 diabetes, for example, in particular, will be around closed loops or artificial pancreas. So people need to have the option of everything on the table. And that's where national procurement comes in. That's how you change pricing structures. That's how we change pricing structures for Abbott. And they're really Libra. So unless you go to national procurements and national things, you can't really do that sort of stuff. So I think the future of diabetes is quite exciting, because, you know, we are also one of the few specialties which has got data, amazing data. Nobody's got data like diabetes has. Every single patient monitor. I can tell you exactly which surgery's got what, and now we've done that with hospitals as well, which is quite exciting. So I reckon type 2 diabetes will go through a lot of changes, with a lot of move towards digital working, a lot of push on diet, self-management styles, etc. And I think type 1 diabetes will very much goes towards loops and stuff. And finally, if we can sort of crack the nut of, you know, people looking at data and stuff, you probably would be able to help a lot of frail elderly, and in the sense of their care homes, data, etc. It's not without possibility of what we can do in this region. So yeah, I mean, I think we're quite proud of landed a fair few things in diabetes. I think the Libra exercise was I think it was a test run, if that makes sense, of the challenges in the system. I could write a book on it about, and you know, lots of people in the call will know, a lot of people don't quite do the jobs they're supposed to do. And I don't say that without flinching at all, because I think a lot of people in lots of positions who should do more if they genuinely want to open up access. And I don't think people do. So that's me. That's it. That's it without slides.
Thank you so much. That was incredibly optimistic, which was lovely to hear, and quite refreshing. Thank you very much. So we will have some time for question and answers towards the end. If anyone on the call does have questions, please feel free to pop them in the chat, and we'll try to get to them, as many as possible at the end. But for now, I will ride this optimistic high and pass it over to our innovators, who will be able to share some more.